Hello everyone, I'm Rongrong Huang. Today I would like to talk about current urine fentanyl immunoassays and how to choose one. I do not have any financial or other conflict of interest to disclose. Here are the learning objectives for today's presentation. At the end of the talk, audience will be able to list currently available fentanyl immunoassays and describe the advantages and limitations of different fentanyl testing methods. The audience will also learn how to evaluate fentanyl immunoassays for implementation based on analytical performance and individual clinical need. Over the past 2 decades, the increase in opioid overdose incidents nationwide has resulted in a significant surge in morbidity and mortality rates. Fentanyl is a major contributor to fatal and non-fatal opioid overdoses in the United States. According to CDC's data, as illustrated in the graph here, the number of drug dose deaths involving fentanyl and other synthetic opioids increased dramatically each year between 2013 and 2022, with more than 50% increases just from 2020 to 2021. In 2022, greater than 2/3 of the overdose deaths in the United States were due to synthetic opioid rather than methadone, with illicitly made fentanyl being the primary contributor. Fentanyl is a potent synthetic opioid, approximately 100 times more potent than morphine and 50 times more potent than heroin. Because of its potency and low cost, drug dealers have been mixing fentanyl with other drugs, including heroin, methamphetamine, and cocaine, increasing the likelihood of a fatal interaction. It is often impossible to identify fentanyl contamination or know the contamination amount without testing, making fentanyl-laced drugs extremely dangerous. Because fentanyl is often laced to other illicit drugs, unbeknownst to users, urine drug testing that can detect fentanyl provides essential information in various clinical settings, including acute intoxications or overdoses as seen in emergency centers, compliance monitoring for pain management, addiction treatment selection for substance use disorders, and the behavioral testing programs. Urine is the most common specimen type for drug testing, including fentanyl. It's easy to collect, and the concentration of parent drug and or metabolites are relatively high in urine with reasonable detection window. Two common methods are used for fentanyl testing, namely immunoassays and mass spectrometry-based methods. Immunoassays is the most widely used screening method, given its high throughput, fast turnaround time, cost effectiveness, and wide availability. We will discuss fentanyl immunoassays in more details in the coming slides. Mass spectrometry-based methods, on the other side, are more suitable as confirmatory tests, given its high specificity. We won't go into details of mass spectrometry-based methods today, but there are many options as well regarding instrumentation and method design. For example, mass spectrometry can be coupled with gas chromatography or liquid chromatography. Depending on the accessibility, you may also choose between standard or high-resolution mass spectrometer. Based on the instrument capability, mass spectrometry-based methods can be designed to perform targeted, limited panel, or untargeted drug testing. Fentanyl is primarily metabolized in the liver to inactive norfentanyl through oxidative and dealkylation catalyzed by the cytochrome P450 family, primarily the 3A4 enzyme. Less than 1% of the parent drug is metabolized into other inactive compounds, such as hydroxyfentanyl and hydroxynorfentanyl. Intestinal metabolism of fentanyl to norfentanyl is also catalyzed by CYP3A4 enzyme at a half rate of liver metabolism. Fentanyl assays are usually designed to detect fentanyl and or norfentanyl. Fentanyl is mainly excreted in urine and feces, primarily in its inactive metabolite form, with less than 10% excreted as intact molecule. Fentanyl is highly lipophilic with a large volume of distribution and relatively long elimination half-life. Similar to other highly lipid-soluble opioids, the half-life of fentanyl is influenced by the duration of administration. It is believed the plasma half-life of fentanyl can range from 3 hours to 12 hours, with a urine detection window of 1 to 3 days. Its major metabolite, norfentanyl, has a longer half-life but similar urine detection window. Even though fentanyl is usually cleared from the body after 2 to 4 days with 1 or a few doses, study has shown prolonged clearance associated with regular use of fentanyl, as seen in patients with opioid use disorder. The mean time for clearance of fentanyl was reported to be 7 days and norfentanyl to be 13 days after last use. It's worth noting that one participant in the same study continued to test positive for fentanyl for 19 days and norfentanyl for 26 days following their last use. Illicit drug manufacturers generate fentanyl analogs through structure modification to circumvent drug detection and regulation. Multiple fentanyl analogs have been detected in drug products and biological specimens over the past decade, and their diversity continues to evolve. The structure and potency of some of the common analogs are presented here in comparison to fentanyl. Immunoassays may have a various degree of cross-reactivity to different analogs depending on the structure difference and the antibody used in the assay. Targeted mass spectrometry-based methods can only detect what they are designed to detect, while untargeted mass spectrometry-based methods have the capability to identify any or all analogs. Most fentanyl immunoassays ran on automated chemistry analyzers are homogeneous enzyme immunoassays based on the competitive principle of antibody and enzyme-labeled drug interactions. As illustrated here by the scheme, when the target drug is present in the specimen, it competes with the enzyme-labeled drug to bind to limited amount of specific antibody that results in more enzyme activity and yields an increased absorbance detected photometrically. In the absence of the target drug in the specimen, enzyme-labeled drug conjugate binds to the antibody and results in a decrease of the enzyme activity, hence a lower absorbance. Similar principle applies to the lateral flow immunochromatographic assays as seen in point-of-care devices, where drug-protein conjugate is stripped on the test band. In the presence of target drug over the cutoff concentration, it competes with drug-protein conjugates for the limited antibody binding sites on the colored antibody colloidal gold conjugate. Once antibody binding sites are saturated, the colored antibody colloidal gold conjugate cannot bind to the drug protein conjugate. Therefore, absence of the color band on the test region indicates a preliminary positive results. Vice versa, the presence of the color band on the test region indicates a negative result. Since the first urine fentanyl immunoassay approved in 2017, namely immunolysis Cephria assay, there have been several developments in the past few years. Second-generation fentanyl assays came out in 2020 have increased sensitivity in detecting norfentanyl, which often presents in a higher concentration than fentanyl in urine. The difference between Lindsay-2 and Lindsay assay is minimal, with both assays detecting and calibrated against norfentanyl with greater than 100% cross-reactivity with the parent drug. Cephria, ARC, and ARC2 assays are calibrated against fentanyl. where DRI assay is a derivative of ARC2 assay. The second generation ARC assay has opted for monoclonal antibody instead of a polyclonal antibody in their assay design, providing improved specificity and increased cross-reactivity with fentanyl compared to the first generation ARC assay. According to the CAP-PT evaluation summary, ARC2 assay is currently the most widely used that can be ran on almost all major automated chemistry analyzers. These immunoassays have a various cross-reactivity to fentanyl or no fentanyl, which we will review in just a few slides. Rapid point-of-care fentanyl testing devices have gained increasing interest, especially for clear-waved ones, given its capability of doing on-site testing for outreach program, remote areas, and walk-in treatment offices. Within a year of the first FDA approval of clear-waved urine fentanyl test strip from last year, 2 clear-waved multi-drug urine test cups have become available earlier this year, capable of detecting fentanyl or no fentanyl. Several studies are published in the most recent issue of the Journal of Applied Laboratory Medicine, assessing the performance of these fentanyl immunoassays through comparison study using mass spectrometry-based method as the reference. These studies reported the performances of fentanyl immunoassays, including ARC2, LINSI-2, Cephalrea, as well as rapid point-of-care testing, in various clinical settings such as emergency departments, inpatient and outpatient psychiatric units, and addiction treatment program for opioid use disorder. Potential causes for false positive or negative results are discussed, as well as result interpretation challenges for low positive specimens due to differences in assay design. Here listed the detection capability of fentanyl and no fentanyl by various immunoassays, as well as 2 point-of-care tests. For no fentanyl detecting assays, such as LINSI, LINSI-2, and CHEM2 point-of-care assay, cross-reactivity with the parent drug varies, but usually high and can be ranging from 50 to 200%. For fentanyl detecting assays, ARC2 has the highest cross-reactivity with no fentanyl, while Cephalrea as well as all tested point-of-care assay are much less sensitive in picking up no fentanyl. It is important to keep these features in mind, especially when interpreting discordant results. The cross-reactivity with fentanyl analogs are assay dependent. Various details can be found in individual package insert. Before we move on to review assay performance, let's have a quick review on some of the definitions. First of all, what is the definition of a positive urine fentanyl result? Generally speaking, detection of fentanyl and or no fentanyl indicates fentanyl use, which is considered positive for fentanyl testing. Some may consider the detection of fentanyl analogs as true positive, extending the definition of positivity for fentanyl testing. Keep in mind that while most immunoassays have a various degree of cross-reactivity with certain analogs, targeted mass spectrometry-based method often detect fentanyl and no fentanyl only by design. On the other hand, fentanyl analogs are rarely identified without the co-occurrence of fentanyl. Therefore, cross-reactivity to fentanyl analogs not only contributes to the so-called false positive, but also contribute to a potential increased sensitivity at the same time. There are also other illicit substances and medications, either prescribed or over-the-counter, that can cause false positive fentanyl results. False negative results are usually more straightforward from an analytical perspective, usually due to lower sensitivity of the assay. But pinpointing pre-analytical factors contributing to a false negative result can be challenging at times. Some of the pre-analytical factors that can lead to a false negative result include diluted urine, adulteration, improper storage, or transportation conditions. Based on review of the previously mentioned studies, the assay performance from 4 fentanyl immunoassays are summarized here. Though ARC2 assay is not as sensitive as Lindsay-2 assay in detecting norfentanyl, they demonstrated similar sensitivity ranging from 89% to 97% overall. Lindsay-2 assay can detect both fentanyl and norfentanyl, with the highest specificity and positive predictive value, as well as the lowest false positive rate reported from both cited studies. Being the first-generation fentanyl immunoassay, Cephria, on the other hand, has relatively high sensitivity but some of the lowest reported specificity and positive predictive value. Higher imprecision has also been associated with the Cephria assay when compared to the ARC2 assay. The all-test point-of-care assay has the lowest reported sensitivity of 84% compared to the other 3 fentanyl immunoassays. Overall, the rapid fentanyl assay had a lower diagnostic efficiency when compared to laboratory-based immunoassays, especially against the second-generation assays such as ARC2 and Lindsay-2. The relatively high reported false positive rates on Cephria and ARC2 assays are likely due to their cross-reactivity with fentanyl analogs. It is worth noting that positivity has been seen in samples with fentanyl and or no fentanyl below the claimed detection cutoffs across all studies, which can be contributed from the cross-reactivity with fentanyl analogs, although it's hard to confirm if targeted mass spectrometry-based method is designed to detect fentanyl and norfentanyl only. A recent study has shown that 51 and 57 out of the 58 tested fentanyl analogs are detected by ARC2 and Cephria assays, respectively, at a concentration less or equal to 100 nanogram per ml. While the N-alkyl chain area has a slightly higher tolerance to variation by the antibody reagents from both immunoassays, the piperidine area in ARC2 assay is of less tolerance to variation compared to Cephria assay. Other interfering substances associated with the fentanyl immunoassays include some common medications, where the level of interference is assay dependent. For example, dextromethorphan, the cough medicine, can be detected by the Lindsay assays. Other medications reported that can be detected by Cephria assay at various levels but not detected by ARC2 assay include labetalol, the hypertension medication, as well as trazodone and risperidone. So, in a brief summary, to better mitigate the risk from false positive or false negative results, laboratories should know the analytical limits of the assays in use, understand the patient population and clinical settings, select proper confirmatory tests to further investigate unexpected screening results. It is also important to ensure the communication channel is open and efficient between the clinicians and the laboratories. With the new Lindsay norfentanyl immunoassays emerging clinical laboratories, its performance in comparison with existing fentanyl immunoassays are compared, specifically in low positive specimens where fentanyl is negative and norfentanyl concentration ranges between 1 to 10 nanogram per ml. Lindsay assays have shown higher sensitivity in detecting norfentanyl compared to other fentanyl assays, such as ARC2, potentially giving the false assumptions regarding timing of drug use, as norfentanyl can stay positive much longer than fentanyl, as mentioned earlier. Clinicians should be aware of the nuances due to assay differences and interpret results accordingly. In the next few slides, I would like to share our experience in evaluating the Lindsay no-fentanyl assay for implementation. The Lindsay no-fentanyl immunoassay was ran on AU 5800 chemistry analyzers, with overall imprecision less than 15% for both negative and positive quality controls, which is comparable to previously published data for ARC2 and Lindsay 2 assays. The comparison studies were performed between Lindsay and the reference Severia immunoassay. Specimens with sufficient volume were also ran on ARC2 assay. Discordant results among immunoassays were sent for targeted LC-MS-MS test for confirmation. Similar to previously reported studies, Lindsay and ARC2 assays compared well, with one false positive detected by ARC2. However, there were significant numbers of discordant results observed between Lindsay and Severia assays. Mass spectrometry results confirmed positivity for all 7 discordant results, with no fentanyl concentrations reported higher than fentanyl in all specimens. A fentanyl cutoff of 2 nanogram per ml for Severia assay and low-level fentanyl concentrations in the specimens tested are likely the causes for the false negative results observed here. There was a near cutoff specimen tested positive by LC-MS-MS but reported negative by all 3 immunoassays. Overall, Lindsay assay has demonstrated an acceptable performance with a sensitivity of 94%, specificity of 100%, negative predictive value of 96%, and a positive predictive value of 100%. In addition to standalone fentanyl order and a standard UDS, we have also created a UDS plus fentanyl panel for easier ordering. Results from all comers on both UDS and fentanyl tests were reviewed post-implementation. The positive rate, test volume, and turnaround time were also compared for a period of 7 months before and after the implementation. We found that turnaround time was shortened by 13-folds, while average monthly volume was increased 1.3-folds. The overall positive rate was increased after the implementation, with a clear switch in ordering pattern from standalone fentanyl to UDS plus fentanyl panel. Also noticed was a slightly higher positive rate in standalone orders compared to the UDS fentanyl panel, which were 15.9% and 11.1% respectively. A deeper dive into the UDS fentanyl panel results revealed that about 50% specimens were positive for UDS and or fentanyl, with fentanyl positive rate of 11.1% overall, which is similar to the previously reported rate. Among fentanyl positive UDS fentanyl panel specimens, about 2/3 were found to be also positive for one or more of the other substances. Fentanyl positive rate was also found to be higher in UDS positive samples than in UDS negative samples, which were 17.4% and 6.1% respectively. In summary, here are the practical considerations for laboratories seeking to implement urine fentanyl immunoassays. First of all, identify the feasible options on existing instrumentations. Then collect information on assay performance, such as sensitivity and specificity, and gain an understanding of the cutoffs, cross-reactivity to fentanyl, non-fentanyl, and analogs, as well as interference from other substances. It is also important to know your patient population and clinical need in order to design the validation study and set acceptable criteria, as well as to plan the implementation. For example, desired turnaround time and assay performance should be considered when choosing among point-of-care device, lab testing, and send-out options. Reflex to confirmatory testing can be done either automatically or manually as an add-on, depending on the clinical practice. Mass spectrometry-based confirmatory tests should be carefully selected to meet the clinical need. Ordering patterns are often heavily influenced by the test design. Therefore, seeking feedback from our clinician colleagues is critical to a success implementation of the new test. With that, it concludes my presentation today. Thank you for your attendance.